by ways of introducing me, my name is Amanda Farrell-Lowe. I'm the Communications Officer here at the Canadian Institute for Substance Use Research. And because I'm working at home, you can also see one of my cats in the background, so that's always fun. And I just want to thank everyone for taking the time to come today and check out the grand rounds on drug checking, implementing harm reduction in dual public health crises. Before we start, I just want to acknowledge that the University of Victoria occupies the the territories of the Lekwungen peoples and the Songhees, Esquimalt, and Wasanich peoples whose historical relationships with the land continue to this day. And I think that's especially important when we're talking about these public health crises that disproportionately impact Indigenous people. So I am going to just stop talking in a minute, but I just want to give some quick housekeeping things. I don't know how many people have used Zoom's webinar, but it's a little bit different than Zoom meetings, which I'm sure most of us have done a lot of over the last little while. You'll notice a little Q&A button at the bottom. This is a great place to put your questions, and you can put them as they come up to you during the presentation. We'll have a question answering period at the end, but folks may have just something might come up to you in the middle, just type it in there. It's a lot easier for us to see it if it's in there instead of the chat, but I will be looking at the chat to make sure that questions don't get missed. And that's really about it. If you'd prefer to ask a question via audio, by speaking instead of typing, you can put up your hand virtually in the there, and I can unmute you so you can talk if that's a preferred method. So I'll be keeping an eye on that as well. So I am going to turn it over to the Vancouver Island Drug Checking Project. You'll see we have quite a few panelists here because it's a very diverse and interesting project, and I really look forward to hearing what everyone has to say. So take it away.
Awesome. Thank you so very much, Amanda. Thanks everyone for joining us for this substance use grand round. We're really excited to chat with you. My name is Pia Barrick. I'm one of the harm reduction workers on the project. So today we'll be discussing drug checking in the midst of two public health crises, so the overdose crisis and COVID-19. We also have 8 people from our team who will be presenting on all sorts of different aspects of the project, and they'll introduce themselves before they go into their slides. So I won't be introducing them right now, but let's get started. Next slide, please. The Vancouver Island Drug Checking Project acknowledges that we are uninvited visitors on the traditional territories of the Lekwungen, Wyoming, and Wasanich peoples of the Coast Salish Nation. We recognize the disproportionate burden that Indigenous communities face in relation to the overdose crisis, as Amanda mentioned. We acknowledge the inextricable links between research, colonization, and racism against Indigenous communities, which continue to this day. Ending the violence faced by people who use drugs and the overdose crisis cannot be achieved without facing the legacy through which we have come to be on this territory. We continue to engage in anti-colonial practices to foster better relationships to this land and the communities and ecosystems that reside here. Next slide, please. I'd just like to take a moment to acknowledge with gratitude our community and our industry partners who not only join us in this process, but also our funders who have allowed us to continue with this critical research and service. I'd also like to acknowledge some of the team members who aren't here right now. So we have 8 folks here, but we have quite a large multidisciplinary team that has ensured that this project continues. So just keep them in the back of your mind. And I won't be going through this list, but I do really want to give a special thank you to the Canadian Institute for Substance Use Research, as well as Island Health Research, who have facilitated this process for us to be here. So we're really grateful for that. Up next, I'd like to invite our 2 principal investigators on the project, Dr. Dennis Hore and Dr. Bruce Wallace, who will give a quick little overview of the project. Thank you. Please go ahead, Dennis.
I'm up next. It's Bruce Wallace, and hi, I'm Associate Professor at University of Victoria School of Social Work and a scientist at CISUR, which is at University of Victoria, also the Canadian Institute for Substance Use Research. So I just want to start by basically a quick definition and a bit of a background, and then we'll sort of jump into what we're doing in our project. So first, a definition of drug checking. Basically, it's a harm reduction approach that allows people to identify the contents of a substance and receive drug information from a peer or a harm reduction worker. It's been most often associated with nightlife and festival settings, and in British Columbia, most of the drug checking and the history and the whole foundations on which we build our project and others is around the work of anchors in the interior and the Shambhala drug checking project, which has been going on for over 16 years at that festival. And we owe so much to the grassroots movements there and also on the island. And so what our project has been trying to do then is to take some of this history of drug checking, taking some of the experience and evidence from that, and trying to really link it also to the current public health emergencies around overdose, and specifically often around opioids also. That's happening not just in a site, but throughout the whole, throughout all the communities. And so with the support of Health Canada and Island Health, Dennis and I have combined with others in the community to be able to link social work, chemistry, computer science, nursing, to work with this project. And I'm going to hand it over to Dennis to describe our objectives.
Yeah, thanks very much, Bruce. It's really hard to describe our project in a nutshell, since there are so many aspects of our project and new shoots that are sprouting all the time in terms of questions we want to ask with our data. But if I were to try to put it broadly, I can divide our objectives into two kinds. So the first type are the scientific objectives. And there we want to really evaluate and compare all those different instruments, or at least quite a few of them that are currently available. It's amazing how many technologies exist for drug checking today, but none of them really are perfect on their own. And one of the things that is really unique about our project is we're willing to give the underlying technology a chance, even if the package is not so good, or if the software isn't where it needs to be, or if there's not a big enough database to search for the drugs using one particular method. So I can understand that, from a service perspective, all these things matter. But from a research perspective, we're willing to kind of build the glue around these instruments to really look at the underlying technologies to see what's available for drug checking and how we can make each of those technologies to be the best that it could be. So along the way, we offer a service. So in the service, we want to provide timely and relevant results on the composition of the substances checked, and also to, where possible, to tell people how strong the drug is to give an idea of the concentration of the active ingredients. And we hope that our tools we've developed that you'll hear about a bit later can mine the data to understand trends and predict where things are going in terms of the drug supply as well. Can I have the next part, please? And then the social objectives here are to provide access to harm reduction education and supplies by offering our service, to develop a framework for evaluating drug checking informed by principles of harm reduction, health equity, and social justice. And finally, we combine this kind of technical data we have with survey and interview data where possible to tell us more about who's using our service and in what kind of settings. Next, please. So to tell you about our project in an overview, the first thing is that we offer drug checking service throughout the city in downtown Victoria. And I know the challenge is that interdisciplinary is a bit of a buzzword these days. And to say, no, we really have an interdisciplinary project is a buzzword again, but we really do, as Bruce mentioned. So we have people in our project from social work, chemistry, computer science, nursing, and at times it's been nearly equal representation from these fields. We really combine science and harm reduction and combine service and research, and they're really intermixed in that project. The one thing that I wanted to mention up front before you hear about more details about different sections is that we use 5 different technologies, and you'll hear about them in detail. We use test strips, we use infrared absorption spectrometers, we do Raman scattering from powdered samples, we put samples in solution, we have a gas chromatograph we use. But the thing I want to tell you is that the goal for us is that every sample that comes in the door is tested in all these methods. We don't decide what's best for a particular sample, even though we might have some notion of that when we see the sample. We really want to have a very large cross section of the data for every single sample that comes in the door. And there's a significant research and reporting objective of our project, and you'll hear more about that later. And we are also very focused on training and capacity building. And we're interested to see what we can do to make a project like this sustainable so that it can be carried out by community partners after this project ends to keep drug checking going in its best way. Next, please.
All right, so I'll be talking a little bit about the service. So we offer a free and confidential service at the Travel Lodge, at AVI, at the Harbor, as well as Lantern Services. So I'll just kind of walk you through what it's like to get your drugs checked. It's a question we get asked quite often. Well, what's the process? So next slide, please. So when you come in to get your drugs checked, you'll be greeted by the harm reduction worker who will kind of welcome you into the space. So they'll go over the service as well as the research, but most importantly, they'll discuss the limitations of the technology with you. So we'll go over the limitations later on in the presentation, but it's really critical that the service user understands what we can and what we can't do in order for them to consent to get their drugs checked. So once they consent, we'll collect a sample and then we'll ask them some questions about the sample itself and why they're bringing it in. I'll show you the questions on the next slides, but this is known as the Survey A pretest. Once they answer those questions, we'll give the sample to the technicians so that they can start running the various checks on the sample. And this is a great opportunity while the service user is waiting to get the results for us to have a discussion either about harm reduction or the substances that they're bringing. Sometimes we'll just talk about how they're feeling that day or the weather, but we'll also offer them an optional survey. And this is kind of a longer survey designed to get a bit more information about what people want to see in terms of a drug checking service. So once the results are once the drug check is done, the results get uploaded into a database and the harm reduction worker will take a look at that database and then they'll be able to give the results to the service user. Once the service user has their results, we'll ask them a few more questions and then we'll have a conversation, anything that they want to follow up on or have more information about. Next slide, please. So these are the service questions that we ask before and after a drug check. So as you can see, before the drug check, we ask them whether they've used a drug checking service before and what drugs they think they have, as well as if the substance had any unexpected reaction. And this kind of helps us to screen for certain things in the process. After the results are done and they get them, we'll ask them whether the service was useful for them. We're always trying to be responsive to people who access our service. And we also will ask them if they're going to do anything differently. So this is a question that we get asked quite often from members of the public or members in the community is do people kind of throw out their substances, let's say if there's something in there. And while that's not the focus of the project, we do try and capture this, but we just really want to ensure that people have the information and knowledge that they need to make an informed decision about their substance. Next slide, please. So this is the longer survey that we offer. It's optional. And one thing I forgot to mention is no one actually has to answer the survey questions in order to get their drugs checked. So you can get your drugs checked without participating in these surveys. But this kind of longer survey, I think it's about 40 questions and it takes about roughly the same time that it takes to do a drug check. So one of the things that we kind of ask about is people's drug use. We ask about their harm reduction practices and whether they've overdosed, and if so, what were the things that impacted that overdose. We'll also ask about demographics, but most importantly, we'll ask about what kind of a drug checking service people who want to use drug checking want to see. And then we'll also ask for feedback about our own service. So this kind of helps us inform our service moving forward. So that's pretty much it for service. And now we'll talk a little bit about how we'll talk about the instruments and research. So I'll pass it over to Ashley.
Hi everybody, my name is Ashley Larnder. I started on the project about 2 years ago through a chemistry co-op position and have continued through research and doing my honors thesis, and after graduating this spring I've been working full-time as a research assistant and a drug checking technician. So I'm going to talk a little bit about the technology that we use on the project. So we use multiple chemical techniques, as Dennis was kind of explaining before. It includes 2 lasers, a mass analyzer, strip tests, and they all give multiple perspectives on a sample. So during service, an incoming sample is measured on each instrument. It gives its own data set, requires its own interpretation, and it all comes together for an overall view and report out on the sample. So this data is stored in the database that our team is able to access through an online platform so that we can conduct further research on it. So in the next few slides, we're going to introduce each instrument and explore some of the research going on behind the scenes. So the strip tests give a simple yes or no answer for the target compound. They're an important way that we screen the drug supply for low-level actives that might not be picked up by some of our bigger instruments. So on our project, we use fentanyl and benzodiazepine strips. They're called an immunoassay strip because they're coated with antibodies that grab onto the target components based on its molecular structure. So for example, the benzodiazepine class of drugs all contain a benzene ring and a diazepine ring in their structure. And this ring group is what the antibodies grab onto. So this allows multiple drugs within the benzodiazepine class to react with the strips, like alprazolam and diazepam. So the strips have the highest sensitivity of all the instruments, but detecting in trace amounts means we may be detecting cross-contamination from other drug types. So for example, someone puts cocaine in a pipe that was previously used for fentanyl. They then bring that cocaine to be checked by us, and we might find a positive strip test. Even though there was no fentanyl in the cocaine, it was only contaminated by the residual in the pipe. So these positive results from contamination do show up in our report from time to time. And as fentanyl and stimulants is a common question we get asked and is a big concern for people, we try to add clarification about the testing circumstances in our reports to ensure that we're giving an accurate representation of the drug supply. So next, Margot is going to talk to us about FTIR.
Hi everyone, my name is Margot. I'm one of the chemistry graduate students on this project, and I'm going to talk about my research involving infrared spectroscopy. Next, please. So how infrared spectroscopy works is it shines a laser beam of IR light at a substance, and then depending on what that substance is made of, as well as the relative amounts of components in that substance, the light is absorbed at certain frequencies, and we can use this pattern of absorption to identify the major components as well as their relative amounts in a sample. Next, please. I'm using infrared spectroscopy to look specifically at illicit opioids. And as many of you might know, illicit opioids in Victoria are generally mixtures of powdered fentanyl and cutting agents. We expect opioids containing fentanyl to be diluted, with other substance because of the extreme potency of fentanyl compared to traditionally used opioids like heroin and morphine. So in Victoria, we see a wide variety of cutting agents being used, such as caffeine and sugar alcohols like mannitol and lactose. And so one of the pieces of information our clients are most interested in is the relative strength of their drugs. So an estimation of the amount of fentanyl in the illicit samples. Next, please. So to achieve this goal, I am using infrared spectroscopy as well as a statistical analysis called partial least squares regression. The combination of this allows me to predict the amount of fentanyl in an illicit sample based on their IR spectra. Next, please. However, as I previously mentioned, a wide variety of cutting agents are used in Victoria. So what I wanted to assess is what happens if there's a third component in the mixture of illicit opioids. So to do this, I created standards of caffeine, fentanyl, and an additional substance such as mannitol, which is a sugar alcohol. And then I predicted the amount of fentanyl in this ternary mixture using the model that I had previously built. And so what I wanted to demonstrate here was, depending on the third component in an opioid sample, both the precision and the accuracy of our fentanyl quantification varies. So for example, when mannitol or erythritol, which are both carbohydrates, are present, the amount of fentanyl is under-predicted. Next, please. Finally, what I wanted to demonstrate is fentanyl quantification data that we have for approximately 400 illicit opioid samples that we've tested in the last 2 years. And what I would really like to highlight is the wide variety in strength that we've been seeing in these samples. And as well, there is the possibility of kind of an increase in the average fentanyl concentration that we're seeing since the onset of COVID-19. And so data like this really highlights the importance of harm reduction approaches and being able to provide our clients with more information about the contents of their drugs. Thank you. Next, please.
All right, thanks, Margo. So my name is Leah Gajelski. I am a second-year master's student in chemistry at UVic. So I do a lot of the research behind the scenes, as well as work as a drug checking technician at Service. So I'm introducing Raman, which is one of the instruments we use, and it's also been a focus of a lot of my research. Next slide, please. So how does it work? Raman spectroscopy bounces a laser light off of the sample and analyzes the light that scatters from it. Some of this light will be shifted in wavelength after interacting with the molecules in the sample. And that frequency and intensity of the scattering provides a spectrum or a chemical fingerprint that can be searched against a reference database for identification. So there's several advantages to using Raman for drug checking. It's very portable, very easy to use, very quick to use. It's non-destructive, so you can keep the sample after. It can also be used through barrier, so through a bag or a container without actually touching the sample. And it also has the potential for trace analysis through an extension of Raman, which is called Surface Enhanced Raman, so SIRS, which is something we do, but I won't focus on today. So Raman is certainly not without its challenges, especially as a newer emerging technology for drug checking. It has quite a high background, which needs to be corrected for. There's a general lack of open access libraries and just generally less familiarity within the drug checking community. So I'm looking to assess Raman and also try to push past some of these barriers. Next slide, please. So Margo talked a lot about quantification of fentanyl with IR, so I won't really touch on that other than to say that Raman has demonstrated its ability to quantify fentanyl as well. And beyond that, there's a huge risk assessment piece that might not be so obvious as we move from lab samples to real life samples. And an interesting part of that assessment is looking at the answer we get from Raman versus IR for the same sample. Next slide, please. So what I've really been interested in is that identification piece. So what's in the sample, as well as automation with drug checking, with Raman in specific, but all the instruments as well. So I'll leave this more complicated slide up as just a bit of a snapshot of some of the work I've been doing, but give you a more basic example to summarize my goals. So if you have Raman and you point it at a pure piece of MDMA, for instance, you will almost without fail get MDMA as the answer using the most basic algorithms that most drug checking projects and software uses. And that's the easy part. But the most challenging part of Raman, and this applies to IR as well, is that there's no separation component. So what that means is when you have a mixture, all of the signals just overlap. And identifying that second or third component becomes a lot more unclear, especially if it's in lower concentrations. So from a technician perspective, I learned quite early how stressful it was deciding that second or minor component, and an answer that ultimately depended highly on technician experience. So I didn't like that and started to dive into what is an insanely large statistical toolbox of data analysis, algorithms, and models. And I'm trying to get creative in their application to drug checking and Raman spectroscopy in specific. and take advantage of the thousands of samples we have to learn from. So overall, I want to miss less, increase our confidence in the results we give, and also move towards that automation piece so that Raman can not only be an accessible option, but a pretty good option for communities who might not have an expert drug checking technician waiting to go. So with that, pass it on to Jared.
All right, thank you, Leah. Yeah, my name is Jared Austin. I'm a research assistant and drug checking technician on with the project. Also a pharmacist in town, and I've helped establish Lantern Services in 2018, which houses Canada's first Section 56 exemption for drug checking to help facilitate research in this area, because there's many red tapes to be jumped around. Next slide, please. So I'll be speaking on the technology of GCMS, or gas chromatograph-mass spectrometry, and Leah and Margot kind of spoke on the different technologies that are a bit more, that are useful. The GCMS is useful in that it's a bit more sensitive, but harder to determine, harder to operate, I guess. So the one we're using in particular is called the Torian T9 by PerkinElmer, and it's one of the first commercially available portable mass spectrometers. And I'll speak briefly on how it works in the next slide, but it's a gas chromatograph and mass spectrometer. So as Leah said, the other infrared and the Raman do not separate out any substances, but this one does with the gas chromatograph, and then it measures it through the mass spectrometer. So you can see there's kind of the diagram on the top, that's the separating out of individual components, and then the mass spectrum on the bottom is the individual kind of fingerprint at a point in time. So as I kind of mentioned, it works very well in conjunction with an FTIR, especially when identifying complex mixtures with multi-ingredients or with low percent actives, like down, which is a combination of fentanyl and caffeine, or heroin as well. So on our project, Torian has been used, we run it with all samples, but it's specifically useful with the secondary testing, with priority samples being flagged to run through to help troubleshoot. Next slide, please. So I'll run through briefly just how the instrument works. So there's 3 boxes. So the sample is first dissolved in a liquid. We use methanol, and it's injected into the instrument through the injector port, and then it's heated up to about 300 degrees Celsius, and it's turned into its gas phase. And this gas mixture is pushed through the long column by an inert gas. We use helium, and it separates out all those components as they travel through the column, and they elute at different times. And then box number 2 is the mass spectrometer. So as the vaporized sample gets pushed through and they get out at the column, they're ionized with the high voltage filament, and as they pass through the detector, they create a specific pattern which acts as a molecular fingerprint that can be matched against our database of pure substances, similar to the other technologies. So there's always libraries to compare against, which is very useful. And then the data readout gives kind of the GC component as well as the mass spectrometer component. So I'll run through a quick example for you guys. Next slide, please. So in the top is the GC component, the gas chromatograph. So you can see the x-axis on the bottom is the time. So there's different peaks kind of eluting at different times. That means there's different kind of ingredients present. So I have some of them labeled. There's NPP, there's xylazine, 4-ANPP, and fentanyl. So of note, there's fentanyl, which is common in down that we do detect. And then there was 4-ANPP, which is a precursor to fentanyl. So it's used in its synthesis. And then due to the technology of the gas chromatograph, how it heats up the chemical to its gas phase, there can be thermal breakdown. So if you click one more time, there's the you can see the structure of fentanyl. When it gets to those high heats, the NPP is actually kind of broken off of the fentanyl. So when we're interpreting this, we must recognize that there can be kind of artifacts. And then as well, when this was ran through the FTIR, there was no xylazine detected, but on the GCMS, there is on the bottom there, that's kind of the MS fingerprint, so to speak, of the xylazine. So that's kind of just an example. Oh, and I guess xylazine is a sedative muscle relaxant, and it doesn't respond to Narcan as well. So it's a dangerous combination when found in down. So this is very useful information to give to people, letting them know that there is something that has potential clinical significance that could impact how they choose to use their substance. Yeah, so that's kind of a quick run through of the GCMS. And it's a very tricky technology, lots of finicky, but it is very sensitive. So it does have some good catches like this. And I think I'll be passing it on to Pia.
Thanks, Jared. So I'm going to be discussing how our team collaborates on research and how this research is being applied directly to our drug checking service. So Jupyter is the online platform that our team uses, which allows us to access all of the data collected during service. So this is where we can analyze data to conduct research, like you heard about in our previous slides, and it's also where we can visualize service data. So we can write Python scripts that can regularly pull data to generate automated reports. For example, the pie charts displaying test strip data for the different drug types. And this kind of data is being displayed on our website currently. So using Jupyter, we can also use our data to answer some questions about the drug checking service we're providing. So for example, how many people are accessing our service? The graph on the right shows the intake of service samples over time. This includes all of 2019 and 2020 data up to and including October, with our highest intake occurring this past August. So looking at a graph like this, you can make correlations to changes due to the season, changes due to our service location and the accessibility of those locations, as well as current events like COVID-19. Since the onset of COVID-19, we've seen our highest uptake in service use to date, which shows the continued importance of harm reduction services like ours. So our goal of a project is to apply all the research data, which you just heard about, directly to our service. And right now, we're currently limited to do this by the current software available. So Jupyter is a way that we can develop our own tools that are tailored directly to our needs so that we can better analyze samples during service. An example of a very basic service tool we've made is the red interactive buttons. So for example, you click on the Run IR Quant Models button. This takes your service sample and applies statistical models to quantify fentanyl. So for example, the partial least squares model that was described by Margot, as well as a comparison to other models that I've introduced in my research. So if you were to click on the Run Database Comparison button, it would take the same service sample and compare it to every other sample we have stored in the database. It then finds the top matches based on the degree of similarity. And we can see if it's something that we've commonly seen, if it's unusual. We can look at the interpretation of that match and if there were any unexpected components found. So with all of the research data and all those tools available, there are challenges in finding a result for the service sample, as well as challenges in translating that result into meaningful and understandable result given to the client. So I'm going to first chat about the technician challenges. So as a technician, we have to interpret the data from each instrument, which sometimes they disagree because they're each giving a different perspective of the sample. We then apply all of our research tools to look at the data and combine all of this information into an overall interpretation, all to find out what's in that service sample. So I'm going to run over a couple common situations that we come across while interpreting the data. So example 1, you only find the compound of interest. Say we have an MDMA sample, and all we find is MDMA. We're highly certain it's there. That's great, we don't find anything else. But there's always the possibility that something could be present below our limit of detection. And we know that some actives are potent at low levels, like fentanyl, which is why it's so important for us to screen our supply with fentanyl test strips. So we also have differing confidence levels. For example, someone brings in a fentanyl sample, which is a mixture of caffeine, sugar, and fentanyl. By looking at the FTIR spectrum, we can detect caffeine with high confidence. It's the bulk ingredient and the largest contribution to the signal. We then find sugar with medium confidence. We know the sugar is present, but we can't tell exactly which sugar it is. And then we detect fentanyl with low confidence. Some peaks stick out, but the majority of the signal is blocked by caffeine, so it's hard to confidently say it's present. So the third example is when no active is detected. So say we have a Xanax tablet that's supposed to be alprazolam, which is a benzodiazepine. With tablets, there are additives and fillers that block out the signal, so we can't find peaks from that benzo. So our result is nothing seen on the instruments and negative strip tests. But from this lack of information, we can still infer things. We know that the strip tests are sensitive to alprazolam, and a negative strip test means there's no alprazolam present. So this means that it's highly unlikely to be a pharmaceutical Xanax tablet. So now Piot's gonna explain how we translate this technician data into a result for the client.
Thank you, Ashley. So yeah, one of the challenges regarding the harm reduction messaging is how to take those complex interpretations that Ashley was talking about and convert them into meaningful information for the service user, and also to do it in a way that's not alarmist. So we practice non-judgment as a guiding principle in our interactions with the folks that we work with. And we also come to this with not only a harm reduction framework, but a framework of pleasure maximization. So we recognize that people use drugs for a variety of reasons. And we want to give people the information that they can use to get out of the substances, to get the things that they want out of the substances that they have. So sometimes when certainty about a result is unclear, harm reduction workers will have to kind of balance providing useful information versus overloading the service user with lots of complex possibilities. So this is kind of one of the main challenges in terms of knowledge translation and in terms of messaging results. So another challenge is that harm reduction workers or the people at the service might not have information regarding the particular substance. So sometimes we get research chemicals, we get tryptamines, we get substances that aren't very common. And so this is why it's very useful to have kind of an interdisciplinary team. We can draw from each other to learn about the impacts of specific compounds, for example. So having the technician or someone who is a little bit more skilled in chemistry is a very useful thing for the harm reduction worker. And lastly, there's a lot of complicated harm reduction messaging that can be given with certain kind of specific mixes of substances, for example. And I think it's really important for us to draw on the expertise of people with lived experience. So sometimes service users will come in and they will have much more knowledge and much more experience about a certain substance or about the effects of a certain substance. And so in that case, what we want to do as a service is not replace that knowledge. We want to supplement that knowledge with other information. But most importantly, we really want to learn from the people who are using our service and recognize that they are the experts of drugs in many cases. Up next, we'll be talking about how we kind of disseminate all of this information. So please, Taya, go ahead.
Thanks, Piot. My name is Taya Von Roda, and I'm a research associate with the project, and I'm going to be telling you a little bit about dissemination of our findings. Next, please. So we do this in 4 main ways. We have our individual results, which are provided to the service user at the time of service on their individual sample. We have reports which we provide monthly and quarterly to partners in the community on aggregate data from the service. Research publications are focusing on methods development, implementation, and evaluation, and include qualitative studies as well as chemometric and other service data. And then website and social media with blog, Facebook, and Twitter, where we're highlighting findings of interest and linking to reports and publications. So I think you've heard a bit about the individual results and the website today, so I'm going to talk about the reports and publications. Next, please. So the primary aim of our reports is to provide data on substances tested at the service to individuals, partners, communities, and policymakers. Next. These reports fit into the general area of monitoring and surveillance of illicit substances. And what that basically means is that we're providing aggregate data on samples tested at the service for different time periods. We developed these in consultation with community partners and Island Health to provide information that was being requested and to allow comparison with other drug checking groups and national data. So we were really aiming to build on existing work while ensuring that we're providing data relevant to community-wide drug checking within the overdose crisis, and that we're considering implications for delivery of drug checking and harm reduction within this context. Next, please. So I mentioned that we have a quarterly report. We go through a number of things here. We briefly introduce our analytic techniques and technologies, and that's because different drug checking groups are using different techniques, and this will influence the kind of information that can be provided. We give the number of samples tested for the period, and as you heard before, that's giving some information around uptake at the service. Expected substances, what were people bringing to be tested? When people come to the service, we ask them what drug they think they have, and then we group this into a number of expected categories, like stimulants, psychedelics, or opioid down, for example. And the number of samples within each expected category is also giving us information around uptake. So, for example, you heard earlier that since COVID-19, we've had increased uptake at the service. And this is really significant because during this time, many harm reduction services were restricted or closed, and many of our service users were displaced. So we had to rapidly adapt to continue to offer services, and we've had increased demand. And not only have we had increased demand overall, but in this last quarter, we had increased uptake in every expected category. So people are bringing a wide variety of substances to be tested, and what this is really showing is the importance of a universal approach as well as a targeted response. So then we go through our detected substances. What did we find? We indicate whether we found the expected substance, and then what other notable components did we detect within the samples. So notable components are things that have the potential for unexpected effects, or that might impact the effectiveness of naloxone, or are a marker of the supply in some way. And then we're drawing out what we think were the important findings for the period, and considering implications for drug checking and harm reduction, and recommendations for policy and practice. Next, please. Our monthly reports are designed to be a rapid scan of substances and components detected for the month. We provide these to partners and others in the field, and now make them available on our website with additional insight and context. And these run through the number of samples, expected substances, and detected substances. Next, please. Research and evaluation. The primary aim here is to develop best methods for design and delivery of drug checking services. Next, please. So as a multidisciplinary project, we're doing this in a number of ways. Instrument and technology, aiming to improve methods, sustainability and scale up, and quantitative estimates of concentration of substances, as you heard about. Quantitative surveys are part of the service and are investigating patterns of service use and reach. Evaluation, how useful is the service for service users, and assessment of service quality. And then qualitative research. We've undertaken 2 qualitative studies where we're really looking to investigate factors that impact service use, strategies and sites for extending reach, and understanding the role of drug checking within this context. In all of our research, we're aiming to build on theoretical perspectives and frameworks around harm reduction, health equity, social justice, implementation science, and we're striving for inclusion and representation. So seeking the perspective of service users and people who use substances, and including partners in our research. Next, please. So to wrap up, I'd like to say that one of the most critical considerations for all of our research, our reports, and our publications is that we're always stepping back, and we're framing our research, our recommendations for policy and practice, and interpreting our findings within a context. So the context of the overdose crisis, of unmet population need, now the dual public health emergencies, and criminalization and stigma. And this context is always changing. And that we're including people who use substances in every step of this process, so that our work is relevant and respectful providing useful information and services, and starting to counter systemic factors of power and oppression. Thank you very much. I'll pass on to Bruce now.
Thanks. So just to quickly talk about how we've been able to do some of the service adaptations during the pandemic over this last year. Next slide. So first is, as we heard, the pandemic had to really shifted some of the other services for people who use drugs and substance use harm reduction services in town. And so we continue to try to follow with our community partners, with the drug user organization and the main harm reduction partner in Island Health in town, to be able to move with them now. So we're operating currently out of a temporary hotel temporary hotel in the restaurant site with an overdose prevention site for injection and inhalation with AIDS Vancouver Island, that's housing people who have been displaced through the pandemic. But that location is also going to be is scheduled to close in the spring. So we'll be looking for a further location as things evolve and move with that. So part of that as a research project, though, is that every time we make changes, we have to make changes to our research ethics too. And we've had the support through Island Health and UVic research boards to be able to make these COVID amendments and to continue service as the organizations realize that the COVID was restricting research, but also we had to respond to the overdose public health emergency at the same time. So finally, I just want to mention that we also realized that we wanted to try to develop a less contact-based service and a more outreach-based service. And so we developed what we call the envelope model, which people can basically do some more self-administration, providing us with samples. And we think this is a model that we could get to be able to really increase the scale and reach, which I'll talk about at the end of the presentation. Next.
All right, so I'll be talking a little bit about some of our advocacy and how we kind of co-locate ourselves with the growing movement of people who use drugs, as well as the growing movement to end the overdose crisis. Next slide, please. So when I was kind of reflecting on this slide, I couldn't help but think of this quote by Cindy Milstein, who's an author who writes about the political and activist potential of grief. And so I'm just going to start off with this quote and then kind of tie it into some of the work that we're doing. So this is from an essay that's titled, "Our Grief is a Starting Point in the Fight Against Fascism." And it's actually in regards to some of the violence that has been happening across the globe and in the States. And in there she writes, "We mourn all that doesn't garner a marble monument or even a humble tombstone. We mourn all that we shouldn't have to bear losing and mourning if we were to inhabit a far more egalitarian, humane world. We mourn all that we love." And she continues by saying, "Through continual practices of collectively mourning our dead and collectively fighting like hell for the living, we'll increasingly find various possible answers to the many painful questions that we're being forced to ask these days." So one of the reasons that this quote really resonated with me is because I think a lot of us, if not all of us, have been impacted by the overdose crisis. We've been impacted by the heartbreak and by the trauma of this crisis. And because of this, we continue to fight alongside the movement of people who use drugs to end this crisis. And so we try and do this in a number of ways. So one of the ways that we're doing it is to call for decriminalization. So as a service that examines the supply here in Victoria, we see the volatility of it, right? We see the adulteration of the opioid supply, and we know that that's caused by prohibition and criminalization. And specifically criminalization of people who use drugs. And so we join others in calling for decriminalization as an intervention in the overdose crisis. one of the benefits of being a point of care community drug checking service is that we can also refer people to other amazing initiatives that are in town. So our friends over at the SAFER project, as well as some of our other community partners, are offering an alternative to the street supply. And as a point of care service, we're able to refer people to that. And we're also able to call on all levels of government to really engage in safe supply as an alternative to the dangerous street supply that we're seeing. One of the really interesting things about this project, and one of my favorite things about this project, is that we have relationships with people who supply drugs, and we also have relationships with people who manufacture drugs. And we know that people who supply drugs have practices of care for the people that they're supplying drugs to, and drug checking is one of those practices. And so we recognize this as an upstream intervention, and we know that when we're able to intervene up here, that's going to have some very important impacts moving downstream. And lastly, one of the really great things about this project has been our ability to build community. So most importantly, building community with people who use drugs and with the folks who access our services, but also building community with our partners, with the places that we're co-located, and just to kind of be present in the growing movement to end this crisis. And I think that's one of the really exciting things about this project that's really close to my heart. And so that's it for the advocacy. And I think we're moving into some takeaways.
Thanks, Piotr. I'm not sure if the next slide is mine. I have to just take a look to see it. Yes, thanks. So I think one of the things that we think about is with a project like ours that has a significant tech focus, there's a danger of reporting anomalous samples or things that we find, scientifically cool and interesting. But one of the things that we've learned early on in the project is that people generally know what their drugs are. So it's not just about unexpected results or bad drugs, but it's also a confirmation that drugs are what people think they are. And we think that there's a real need to report the obvious things which are not really written about or reported very often in the project. Piotr just spoke about the interest from suppliers and supply level testing that we try to do a really good job with because it has the ability to impact many people. You've heard a lot today about all the development we're doing on the software end for the instruments, and the real need to not only identify what's present in the samples, but to be able to report on the concentration of the active ingredients, which is a real challenge that we take on. Next, please. And finally, there's a real need for destigmatizing drugs and increasing conversations with people about the drugs that they're bringing in to have tested. We realize that access and appropriateness for diverse populations is currently limited, and we're constantly thinking about ways to improve that for people. And we're working on our advocacy and engagement in creating safe supply. We've also learned that how we perform those services, where we perform those services, and who's performing the services really matter in order to impact the community with drug checking. And finally, there's one more thing I wanted to say. You've heard a lot today about all the efforts we've used to create a very versatile data analysis and reporting platform. In the beginning, one of the ideas we had is that we'd open our platform up to partners as well, so that it's not just us going in there and analyzing the data, but people with their own research platforms can do that too. And over the years, we realized that realistically, we're the ones who are going to be using it to answer our own research questions. So we haven't really pursued that, but we would like to open the invitation to the attendees out here, in particular our partners at Island Health. If there are research questions you're interested in from our data, please feel free to contact us, and then we can prepare some reports for you, either a one-time report or an annual or monthly report in a very automated way that addresses questions you're interested in. Thanks.
So I get one of the final slides around just how we're moving forward. One is that we're going to continue to be an adaptive service model. As I mentioned, a lot of the adaptations recently have been in response to COVID redesigns and also the displacement of people because of COVID. But we also want to move forward with the movement towards safer supply, and here locally with SAFER, the project, but others, and also recognizing the movement towards decriminalization. and how drug checking can fit within decriminalization, as some ways doesn't really address some of the different supply issues. We have a real significant objective around ensuring that drug checking has significant scale and reach. So a significant enough scale and reach to be impactful. So scale means that we're going out and we're being able to not just be a pilot project, not just in a single site in a single city, but actually reaching the diversity of population of people who use drugs. And reach means that we're reaching that diversity, not just a general universal approach, but actually being able to have a project or services that are tailored to meet the unique needs of unique populations within people who use drugs, people who sell drugs, and family members. We want to create, as a research project at University of Victoria, some practice-based evidence to be able to inform the scale and reach. So as Dennis is talking about, that's new technologies. In many ways, some of these technologies, as it pertains to drugs, have been used in the war on drugs. They've been used around enforcement, military, border crossings, and we're trying to develop them for harm reduction purposes. And how can the information from these technologies be used best to inform people who might be using or selling drugs? Also, the practice-based evidence for increasing scale and reach is around training. So how do we have training in harm reduction? How do we make sure that there's technicians that can operate these instruments, and not just in large urban areas, but throughout more rural areas also? And then as some of the questions have come around, just to the context too, how does drug checking actually function within the context of criminalization and within stigmatization? Lastly is just as ongoing sustainability questions. Some of the funding for the projects have come about because of the public health emergencies related to overdose, and they are pilot projects and there are research projects, and we get research project funding, which is really great. But I think we have to also be looking in the future around what is the sustainability of drug checking within substance use and harm reduction work. So over to the last slide.
All right, well, thank you, everybody. That's it for our presentation. A little bit of promotion over here. If you want to send us an email, our email is substance@uvic.ca. Our website is substance.uvic.ca. And please check us out on Twitter, SubstanceUVic, as well as Facebook. We often share things on our Facebook, on our Twitter, and we love networking with other people who are interested in drug checking. So please take a look. And I think we're going to be moving into a question and answer period. So I think what I'll likely do is, if people wanted to either write their questions in the Q&A, and I see that there are some there already, and then I'll just try and refer that to the best person who would be able to answer it. And there might be a few of us answering the same question. So maybe I'll just give it a little bit of time for people to write their questions, but let's see. Oh, it looks like we already have some questions.
Yeah, so Piot, if you could read them out loud, that'd be great. So people, yeah.
Yeah, so awesome. Maybe I'll begin with a question that's already answered, just in case people are on the phone call, but I'll read it out loud. It says, "Hi, Carol from Melbourne, Australia. My question is in two parts. I know that they have started trying to test street drugs here, but now how have you been able to gain the trust of the clients so that they will come in to have their drugs checked? And part two, in regards to the police, are they on board and not waiting outside the testing areas to check on clients coming out?" So Bruce, you answered that. Would you like to answer that again?
So yeah, I provided a written answer in the Q&A, but basically for the trust it is a really significant issue. So, you know, on this thing, it's a good question. And the way that I think that we've been most apparent in it is by working with the community groups that already have the trusted relationship in communities. So here in Victoria, that's working with the local drug user organization, Solid Outreach, and with the main harm reduction service provider, AIDS Vancouver Island. And we also work with Island Health. And through those connections, I think that they sort of develop a lot of the trust for us as we co-locate with them. At the same time, we're hoping we do more around other parts of the role in that. But I think like there's much more to say about that. But I think just in the time, I think that that's one of the most important things, is that it's not a university project parachuting communities, that we basically try to continue to make sure that we have relations in community and we have that back and forth. And that's where the trust, I think, comes from more than what we actually do quite often. It's the collaborators that hold that trust, and that we piggyback on that in many ways, I would say.
Thanks, Bruce. I think that kind of also answers a little bit of the next question, so I'll just read it out. I'm curious how you are going about leaning into and learning from the expertise of people with lived experience, and how their voice and expertise is captured in the project from its inception to its dissemination. I might answer a little bit more about this. I think Bruce already mentioned that being co-located with some of the kind of amazing organizations who already have this established relationship with people who use drugs is really important for us. So just really want to specifically name AVI and Solid here. And so I think that there are ways in which we can do this better. And I'm often reflecting on the ways in which research has exploited people who use drugs. And I think, yeah, this is always such a challenging question for me. So one of the things that is really great is that we have kind of a collective of people who use drugs, who are kind of involved in the street community and also involved in some other forms of advocacy around substance use, who are really big fans of the project and are also kind of engaging with the project in different ways. So for example, they'll come and let us know about a batch that's coming in, or they will come and ask us about what we're kind of seeing, and they'll relay that to their folks, or they'll write it out through screens. There was a time there where AVI and Solid together were doing a dope guide, and we would kind of feed into that information as well. And the dope guide was kind of this kind of street-based publication which looked at the various kind of user experiences of substances. And so I guess what I want to say is that we try and engage folks with lived experience in lots of different ways, and we can do that much better, and we're not doing that as well as I think we can right now. So it's always a kind of continual process. Also before COVID, we were having regular meetings where we invited our partners, and some of our partners are people who use drugs. So we invited them to give us feedback on some of the things. All right, let's see if there are other.
I was going to add a little bit more there. I thought maybe Bruce might step in too.
Questions, I think.
There's a few other ways that we're including people as well. Just to mention that we include community partners in the qualitative research that we're doing, and we specifically seek the perspective of people who are using substances in that research, so that it's really trying to find out what they're looking for in a service, what might be barriers and facilitators from their perspective, what are impacts that they think the service will have. So kind of reframing the role of the service from their perspective, and trying to ensure that we're really meeting people's needs and having that inclusion and representation. So that's another piece that's also being done.
Thanks, Taya. So it looks like the next question is from Amanda. Thank you for this presentation. I'm curious about the kind of feedback you receive from people who use drugs on the kind of service they want or are looking for, and whether this information can help expand outreach or modify the service. So I think, Taya, you touched on that a little bit. Do you have any more information about some of the answers that we're getting in our feedback?
What I don't have answers around, which you would have from being at the service, is particularly around the use of the service. But we are like seeking to understand what's needed to implement drug checking from the perspective of service users. And I think you've already touched on some of those things before. So like the critical importance of trust and of confidentiality and anonymity, and also of really recognizing the context within which the service is trying to operate. So the fact you really needing to attend to criminalization and stigma, and that if you're not addressing those barriers, like that's a really critical piece in terms of how to deliver a service that's going to work for people. And I think another aspect is really seeing in our research that substance use is really common across demographics, and that it's not just one type of person who is seeking the service or benefiting from it. And so I think you heard about this as well, the need to really reach those diverse populations. And how can we best do that? So that's what some of the qualitative research is trying to do, is to really talk through and explore how do we develop services and what strategies and sites are going to help reach different populations so that we can be most effective.
Thank you, Taya. I don't know if I have too much to add to that from service. So people quite often, like in general, we get really good feedback from service. People are really excited about kind of the anonymity, the confidentiality, but also kind of the relaxed environment that we're in. So I think people really appreciate being around the folks from AVI. AVI is a fantastic organization. And there's kind of like a really chill flow that exists at the service. And I think people really appreciate that. It doesn't feel very clinical. It feels very kind of community based. All right, so it looks like there's one more, and it's, so from Emma, I suppose to expand on that, which you are touching on a bit here, but how is the project, or how the project is or is not doing so in a way that's both ethical and equitable? Bruce, would you like to touch on that?
Sure. I think, and it sort of builds on like how are we reaching on some of Taya's answer. Like I think when we ask people like what should drug checking look like, often we would get a response, well, it should be everywhere and all times of the day and every part of the city. And so there is this, it's hard to be able to figure out how to do this equitable response, but a bit of the equitable is this sort of universal and targeted, I think. So in some ways, drug checking, I think, has a role in recognizing that drug use is part of society. It's not about trying to stop use. It's not about scaring people about drugs. It's actually about providing as much information as possible about drugs to people who might be interacting with them in the many different ways, as a family member, as a person who might be selling, a person who might be using drugs, as a harm reduction provider. And so it's looking at that and trying to provide that information, but then it's also like how to make sure services are appropriate for that diversity of people too. And so we're trying to figure out like what are the different ways that we can respond to those sometimes really different needs and the different ways people might want the service set up, and how we respond or how we communicate the results. But I think overall, I think it's around this ethical and equitable question is around that recognition that we have an ethical mandate to provide as much information around the composition of drugs and the information we can provide, the interpretation of that composition to people, to be able to provide as much information to people as possible. And we do that on an individual basis, but then we're also trying to do it on the bigger, on reporting on the aggregate data. So how do we provide that information to the general public or on our website, for example, like to make sure we're not feeding into like all drugs are bad or dangerous, while also providing the information on what we are seeing at the same time and where we do think that there's real unpredictable supply. So those are some of the challenges that I think that we're dealing with. But I think it's a challenging question. I really appreciate it because I think it's what we sort of struggle with whenever we have our Thursday team meeting. So I really appreciate the question, Emma.
Thanks, Bruce. So maybe I'll just give a bit of time. I'm not sure if people can ask questions, Amanda, through their microphone or if it has to be typed out, but maybe if
Yeah,
someone has
if
questions
anyone,
that they want to just say out
yeah,
loud.
if anyone would
Go
like
ahead.
to talk, they can put their hand up in the in the attendee where they see the list of people on the call, and they're welcome to do that, and I can unmute you if you'd rather speak a question. That's an option. Okay, I've got Emma would like to ask another question, so I'm just going to unmute Emma. There you go, Emma.
Sorry, I've got lots of questions over here. I'm just curious, so part of the presentation today talked about trying to work towards destigmatization and just tackling some of that stigma. I'm wondering if your intention is to use any of the research to shift policy, recognizing that a lot of this stigma stems from really violent and oppressive policies around drug sale, purchase, and use. Yeah, I'm just curious if any of the research is hoping to shift policy at all.
Bruce?
I was just gonna say yes. Yeah, it's as a community-based research project, like it's not around just creating evidence on here's what we're finding. It's very much that this project is very much about addressing the issues that are basically the systemic reasons that there are risk and harms, and so that is exactly why we want to take it on. And it's also sort of what raises the question around the sustainability, is how do we make sure that some of these responses are not only coming from a research question, but actually integrated within public health responses.
Okay, I think that seems like everyone's been able to ask their questions. So thank you to everyone for coming, and thanks to our presenters. I know it's been echoed in the chat, but this is such an interesting project. I also want to give a special shout out to Island Health. I forgot to mention them at the beginning of the presentation. They are actually co-sponsors of this event. So thank you, Island Health Research, for always co-sponsoring our substance use grand rounds. We really appreciate it. And yeah, the project website is up there. And if you'd like to learn about more of these events, we do them about quarterly. These substance use grand rounds, we switched to online. They used to be in person. You can go to CISUR's website at CISUR.ca and sign up for our mailing list. And I'm sure Island Health also has an excellent mailing list. So thanks, everybody, and thanks to all the presenters.
Thank you, Amanda.